everybody else, but not me. I won't be impacted, or even if I am, it won't be a big deal. It'll be like a cold and I'll get over it. What can we possibly say to people to prove to them that they are not invincible from this virus?
It's really hard to get through to individuals who often think it won't be me. And that's because, as we know, a large proportion of people infected with SARS-CoV-2 that leads to COVID-19 do just fine. However, we have to really think about what we don't know. What we don't know is how long symptoms are going to last. So, we've often focused obviously on the worst outcome, that being death and hospitalization. However, those individuals who end up with long haul COVID, those symptoms are debilitating. One's quality of life, their ability to make a living are going to be affected. And, we're taking these strategies such as requiring negative tests to be able to get into the United States. But even that is not foolproof. And so it is a mistake to think that relying on testing is going to put us in the clear. What we really need at this point when people return home is that individuals adhere to isolation and quarantine policies recommended by their state and locality so that we can stop this spread.
So, Paige, I want to turn to you on this one because one thing that I think has been left out of the conversation is vulnerable communities when it comes to the vaccine. And you're reporting how much of the conversation is about how do you get vulnerable communities vaccinated? I mean, that goes from, we just had somebody who was recently released from Angola, the prison population, but also low income and historically disenfranchised communities. They might not have means, money, or transportation to get vaccinated. What have you uncovered in your reporting about that?
Well, I think certainly when we get to, we're at this first tier of vaccination at this point, right? So the long-term care residents and the healthcare workers are getting the vaccine. And that's much easier than any of these other populations to get the vaccine to, because these are in facilities, institutions. It's going to be much harder once we get down to those lower tier folks to get these vaccines out. The government has partnerships with CVS, Walgreens, a number of other companies. And so the idea is that working with these pharmacies, they're actually going to be able to identify who these essential workers are to make sure that the people that qualify for this next tier of people getting vaccinated are able to get vaccinated. But it's certainly going to be sticky. I mean, the government has never tried to do a vaccination of this scale before. And even the discussions about, who should be in the next tier after the long-term care and healthcare workers. Should it be the essential workers? Should it be the people over age 65? Even that there haven't always been agreement on.
So I want to stick with you, Paige, for a second here, because this is without a centralized federal response. A lot of these decisions will be left up to the states. And so that's concerning to me because you've got governors like Florida man Ron DeSantis and also, I didn't know asymptomatic people could spread COVID, Governor Brian Kemp. So in your reporting, do you have an idea on who at the state level is making these decisions?
Well, it's been the responsibility of the state public health departments to figure out which providers are interested in providing the vaccine. So what I've heard is they've been talking to, these pharmacies, they've been talking to hospitals, and supposedly then when the vaccine is shipped into the state, they already have decided where the different doses and how many of the doses where they're going. But certainly we're going to see a diversity of approaches among the states in terms of who is prioritized. One could argue that, the states have different types of population makeups, different demographics. And so it is reasonable to think that there would be some differences there in who they think should get the vaccine first. But, again, this process is going to be messy. We've already seen some hiccups in getting the vaccine shipped out. But I will say one positive note is that we have seen almost 10 million doses shipped out at this point, and this is less than 2 weeks after that first Pfizer vaccine was given emergency use authorization.
We have seen some of those vaccines shipped out, but I do want to point out that even though more than 1 million Americans have received the vaccine, the government's Operation Warp Speed Vaccine Accelerator has already kind of softened some of those expectations and is saying that they're not sure that they'll make good on the goal of vaccinating 20 million people by the end of this month, so we'll have to see what happens. Dr. Carnethon, I want to turn back to you. Have you had the vaccine, and if so, how do you feel?
I have not had the vaccine because I am in an administrative role as an epidemiologist. I review data and make recommendations and patterns. But, one thing that I would emphasize from my perspective is that individuals should take their turn when it's time to be vaccinated. There's a lot of vaccine hesitancy, and disappointingly, that hesitancy is coming from some of the most vulnerable communities. Certainly, the reasons for the hesitancy can be understood, grounded quite often in historical mistrust of the medical care system, particularly in minority communities and impoverished communities. However, this is an opportunity for us to ask questions. And I think that a lot of the messaging, and in particular the public vaccinations by our leaders, should provide some measure of reassurance that individuals believe this to be safe. But even that is not going to do the trick. What we need are for healthcare providers not only to tell individuals that the vaccine is safe, but to ask questions, to invite discussion around why one is concerned about the vaccine in order to help allay some of those concerns, because we will not reach herd immunity if we have large proportions of our population, particularly those who are in a position to be super spreaders, refusing to vaccinate.
So let me stick with you on that, because this mutation out of the UK, we've seen evidence of it in the UK and South Africa. I know people are still learning about it, but how concerned should we be, particularly as it relates to the vaccine? Will this be like the flu vaccine, that we have to develop a new one every year? Or will this vaccine be able to address the mutation that we've seen?
So vaccines mutate. So that finding in particular isn't surprising. Vaccines do what they can to keep themselves alive and to continue to be able to spread. My understanding of the current vaccine is that it, as an mRNA vaccine, it is specifically targeting the route in which the virus enters the cells of the body to be able to infect the body. My understanding is that it is meant to be more robust to these minor mutations. However, we cannot be sure that it won't require repeated vaccinations every year or every other year as the virus continues to mutate.
All right. Well, we're definitely going to keep following this story on this show. I think a lot of people have a lot of questions and concerns about the vaccine. So, Dr. Mercedes Carnethon, your input is certainly helpful. And Paige Cunningham, I love your reporting at the Post, so I thank you for making time to join us today. So thank you both for joining us. You've been waiting